Hi, everyone. My name is Erin Campbell, and today I will be presenting on dementia with Lewy bodies, or DLB. I would like to extend a warm thank you to Pat Snyder for the invitation to present today, as well as for the amazing work that Pat does for the Lewy body and dementia community. I am hopeful that what I have to share will be helpful to all of you. My connection to DLB is that I was my mom's primary caregiver up until her death from DLB in 2023. My mom's difficult journey inspired me to pursue a midlife career change and go back to school to study dementia with the eventual goal of becoming a DLB researcher. I am currently in graduate school studying neuroscience. I am passionate about helping patients, caregivers, and the general public better understand DLB, as well as the ways in which those who are affected can be more acutely supported. I recognize that DLB can be isolating and overwhelming for patients, as well as for their caregivers and loved ones. Knowing what you are dealing with is sometimes half the battle. Therefore, I hope to provide educational resources to aid in the navigation of DLB diagnosis, treatment, and disease management. Additionally, I am hoping that this presentation will clarify the importance of getting an accurate dementia diagnosis early in the disease process. Dementia is often wrongly accepted as a normal part of aging, which it is not. And dementia is often lumped together as one giant beast. But in reality, there are many types of dementia, and each type is unique and requires specialized treatment. The more we learn about the different types of dementia, the better chance we have of diagnosing appropriately and knowing how to help. I recognize that many people in attendance are quite familiar with DLB, whereas others are just beginning to learn about it. So I've tried to find a balance of providing scientific background as well as practical resources for patients, caregivers, and health professionals. Here is a brief overview of the topics I will touch on. First, I'll begin with a little background on the biology of DLB. Second, how DLB is typically diagnosed. Third, how DLB is treated. And finally, and perhaps most importantly, how and where patients and caregivers can find support, resources, and help. So, what is DLB? First, it is a neurodegenerative disease classified as a synucleinopathy, which I will more clearly define in a few slides. Second, DLB is sometimes referred to as the second most common form of dementia that no one has ever heard of, because despite its prevalence, DLB is not particularly well known, and this is true even among some healthcare professionals. Third, DLB has a vast array of symptoms. Importantly, some of these symptoms are treatable. Fourth, antipsychotic medications are often contraindicated, meaning they can cause severe side effects. So, knowing what medications a patient should avoid is really important. I will go over these medications later in this presentation as well. Fifth, early and accurate diagnosis is the key to improve quality of life. As many of you have probably experienced, DLB is a roller coaster. The symptoms can fluctuate dramatically, particularly in the early stages of the disease, which can make diagnosis quite challenging. Sixth, DLB has no known root cause. With other forms of dementia, like Alzheimer's, for example, there is an understanding that a combination of genetics and environmental factors are involved. Researchers have identified familial patterns and genes of interest that increase someone's chances of developing Alzheimer's. But with DLB, we have been unable to find genes, familial patterns, or environmental triggers that are consistently associated with any sort of predictive risk. This is not to say these factors do not exist, rather, we do not yet know what they are. Finally, DLB is one presentation of Lewy body disease, which is the umbrella term for several different disease presentations, which I will elaborate on shortly. First, to provide some historical context, this gentleman, Frederick Lewy, is the researcher who discovered what he noted as inclusion bodies in the neurons of patients with Parkinson's symptoms in the year 1912. We now refer to these inclusion bodies as Lewy bodies. Dr. Lewy worked in Alois Alzheimer's laboratory, which is a name that most people likely recognize. When World War I started, he became a military medical officer for Germany, which was his native country. But because he was born Jewish, he fled Germany in the 1930s when the Nazi regime took over. He first escaped to London and later to the United States, where he became a citizen and served as a physician in the United States Army. Eventually, Dr. Lewy finished his medical tenure teaching at the University of Pennsylvania. Visuals can sometimes be helpful, so here are two pictures of what Dr. Lewy first identified. These pictures show what a Lewy body actually looks like. The picture on the left is a real image taken under a microscope of the inside of a nerve cell. And as you can see, the Lewy body stands out from the rest of the cell in that it is very distinct in its structure and appearance. The picture on the right is a more simplified drawing, so it is a little bit easier to identify what you're looking at. The arrow indicates where the Lewy body is located, and the cell nucleus is identified in the picture as well. So we just saw some images of what Lewy bodies look like structurally, but what are they actually comprised of? Lewy bodies are caused by the buildup and consequent abnormal behavior of a protein called alpha-synuclein, which is pictured on the right-hand side of this slide. Alpha-synuclein is a neuronal protein that is found naturally in abundance in a healthy brain, as well as in the heart, peripheral muscles, and other tissues. The presence of alpha-synuclein is normal and not the problem. The problem starts when this protein begins to behave abnormally in an unchecked way. We don't understand what causes this protein to misfold and clump in DLB. If we knew that, we would be much further ahead in the field of Lewy body research. The main role of alpha-synuclein is to control neurotransmitter release, so it is one of the many signaling mechanisms that allow neurons to communicate with each other. There are other diseases that can also be caused by excessive aggregation of alpha-synuclein, such as multiple system atrophy. Any disease that is caused by excess clumping of alpha-synuclein is categorized as a synucleinopathy. When those synaptic connections go awry and Lewy bodies begin to form, these Lewy bodies can accumulate in different parts of the brain. And depending on where they settle, a person will be affected in various ways. Lewy bodies can begin their accumulation in any of the three areas of the brain highlighted on this slide, and then spread to other parts of the brain. If a person exhibits the symptoms listed underneath each of the three brain regions, then that is likely the part of their brain that is impacted by the Lewy bodies. So if Lewy bodies settle in the brainstem area, then symptoms such as movement, blood pressure, and sleep cycle control issues develop. If they settle in the limbic parts of the brain, then emotions, mood, smell, and a person's sense of reality can be altered. Finally, if the Lewy bodies settle in the cortical parts of the brain, then vision, cognitive tasks like attention regulation and judgment, as well as memory and language are affected. This diagram demonstrates the different presentations of Lewy body disease depending on where these Lewy bodies first begin to form. If Lewy bodies begin clumping in the parts of the brain responsible for cognition and emotion, then a person develops dementia with Lewy bodies. If the Lewy bodies first begin clumping in the parts of the brain responsible for movement, then a person develops Parkinson's disease. Both DLB and Parkinson's are progressive disorders, so these Lewy bodies can spread throughout the brain as the disease advances. Therefore, people with DLB can develop symptoms of Parkinson's if the Lewy bodies spread to the parts of the brain responsible for movement. And similarly, people with Parkinson's can develop dementia if the Lewy bodies spread to the parts of the brain responsible for thinking. This latter scenario is typically labeled Parkinson's disease dementia because it starts as Parkinson's and then develops into dementia. So Lewy body disease is the umbrella term for Parkinson's disease dementia, and dementia with Lewy bodies. Since Alzheimer's is something that most people are familiar with, I thought it might be helpful to show some of the ways that DLB is different from Alzheimer's. As you look at this comparison table, please be mindful that these descriptions represent those who have DLB only and Alzheimer's only. In reality, as we will see on the next slide, people can have both pathologies. Autopsy studies have shown us that DLB and Alzheimer's frequently appear together as co-pathologies. In people with both or other overlapping dementias, the symptoms will overlap. So, with this distinction in mind, the prevalence of Alzheimer's is much higher than DLB, but also it is important to remember these numbers reflect diagnosed cases only. There is reason to believe that there are many undiagnosed DLB and Alzheimer's patients, as well as likely many DLB patients who are misdiagnosed with Alzheimer's. The underlying cause of DLB is unknown, whereas Alzheimer's is thought to be caused by a combination of specific genes, as well as a variety of environmental and lifestyle triggers. Both DLB and Alzheimer's are caused by abnormal protein folding in the brain, but these culprit proteins are different. In Lewy body disease, the protein that misfolds is alpha-synuclein, whereas in Alzheimer's, the proteins that misfold are beta amyloid and tau. As for cognition, what I would like to highlight is that DLB is not so much about memory loss, whereas Alzheimer's definitely is. This is not to say that someone with DLB will not experience memory loss, because some people do. But in those with DLB proper, in other words, no overlapping other dementias, the cognitive issues are less about memory loss and much more about executive functioning challenges, such as reasoning, problem solving, and fluctuations in alertness. My mom, for example, never really exhibited memory loss, so much as extreme confusion in terms of where memories fit into a timeline. She would insert people and events into the wrong chronological place, but her short and long-term memories were fairly well preserved, even in the later stages of her decline. REM sleep behavior disorder is very common in patients with DLB, so much so that it is considered a core clinical feature. As far as recognition and awareness, DLB patients are often able to recognize people and faces up until the moment they die, whereas Alzheimer's is characterized by increases in loss of recognition over time. So if a patient with DLB has no other overlapping types of dementia, then there is a good chance that they will never forget who their loved ones are. Hallucinations, particularly visual hallucinations, are extremely common in DLB patients, with approximately 80% experiencing visual hallucinations early in the disease process. Hallucinations are sometimes the first symptom that DLB patients experience, and they can fluctuate in frequency and severity as the disease progresses. With Alzheimer's, hallucinations early in the disease are very uncommon, but in the later stages, approximately 20% of Alzheimer's patients experience hallucinations. As far as movement, DLB patients can experience specific challenges. Muscle rigidity, stiffness, tremors, and falls are common. These movement symptoms can also ebb and flow the same way that the mental symptoms can. Alzheimer's patients do not characteristically have disease-specific movement challenges like DLB does, but as any dementia advances, spatial awareness can potentially become compromised, which can lead to movement issues. Finally, smell is an important symptom to discuss. Loss of smell or reduced smell is very often the first symptom in Lewy body disease. This was my mom's first symptom, and it preceded any other symptom she had by at least 5 years. In Alzheimer's, loss of smell is not as characteristic as it is in DLB and Parkinson's. So we just saw how DLB and Alzheimer's are different, but there is also the possibility that someone may have mixed dementias. And interestingly, DLB and Alzheimer's seem to overlap quite frequently. Specifically, upon autopsy, as many as 50 to 70% of DLB patients meet Alzheimer's consensus criteria. And similarly, approximately 50% of Alzheimer's patients show Lewy body pathology upon autopsy. So, how is DLB diagnosed? A DLB diagnosis is made by looking at two main things: clinical features and indicative biomarkers. On this slide, you will see two types of clinical features: core clinical features and supportive features. And I'll give you a moment to take a look at these. The second factor involved in DLB diagnosis are indicative biomarkers, which are displayed here per the 2017 DLB Consortium guidelines, which are the most recently updated guidelines that we have. None of these tests alone are definitive enough to make a diagnosis with 100% accuracy, but when used in combination with a clinical exam, consideration of core clinical features, and patient history, these biomarkers can aid in diagnosis. So, putting together what we just saw on the two prior slides, a DLB diagnosis is considered probable if two or more clinical features of DLB are present, with or without the presence of indicative biomarkers, or one core clinical feature is present, but with one or more indicative biomarkers. There are two diagnostic tests that have become available in very recent years that are remarkably accurate at diagnosing the presence of alpha-synuclein in nerve fibers. The first is a skin biopsy test called SYN1 that was created by CND Life Sciences. SYN1 was able to detect alpha-synuclein in 96% of DLB patients. And importantly, some of these patients were in the very early stages of the disease. The test is minimally invasive. It is a tiny skin biopsy in 3 specific sites. The test is covered by Medicare, and the SYN1 website provides a patient access team with an email address and telephone number listed on this slide for patients to contact if you need to have your out-of-pocket costs potentially reduced. If you or someone you know is interested in having this test done, there are several academic centers that perform this test, a local one being UNC Neurology. But if you live far away from an academic center, you can ask your primary care doctor if they would be willing to do this biopsy. And if so, you or your doctor can order a testing kit directly from CND Life Sciences. The company provides training videos for whoever will be doing the skin biopsy, so if geography is limiting you from getting this done, it is worth asking your local doctor if they're willing to perform this test. Another test that is fairly reliable in terms of accuracy is called the SynTap cerebrospinal fluid test. This test is more invasive than the skin biopsy because it involves a lumbar puncture, and it is currently not covered by Medicare. So, how is DLB treated? There are some pharmacologic interventions that may help, specifically with cognition, movement, and mitigating psychosis. The generic name of these medications is listed in the middle column, and the brand name is listed on the right. Please be mindful that this list is not all-inclusive. I would like to highlight the first 3 medications under the brand names Aricept, Exelon, and Razidine. These are cholinesterase inhibitors, which are considered the first line of treatment to improve cognitive impairment. They work to erase the inhibitors of acetylcholine, which helps DLB patients since they often exhibit significant decreases in cholinergic function. There are also quite a few medications that may cause harm and should be avoided if possible. And again, this list is not all inclusive. On the left-hand side of this slide, you will see a list of general medication categories to be careful of. On the right-hand side of this slide, you will see a more specific list with generic and brand medication names. I would like to call your attention to a few things. First, antipsychotics should be approached with extreme caution, as they can cause extreme reactions such as worsening confusion, heavy sedation, and increased Parkinson's symptoms. One particular antipsychotic called haloperidol, or sometimes referred to as Haldol, should be altogether avoided. Haloperidol is frequently administered in emergency situations to help calm someone down. EMS gives haloperidol frequently, as do emergency room personnel. However, in DLB patients, haloperidol can cause severe reactions, so it is important to list this medication as an allergy, even if a DLB patient has never actually been administered it. I had haloperidol written as an allergy on my mom's medical bracelet, and the ER still tried to give it to her on several occasions. So it is really important to try and stay on top of what medications are being administered to your loved one in emergency situations. Second, an over-the-counter ingredient that can potentially cause great harm to DLB patients is called diphenhydramine. This is the main ingredient in Benadryl, as well as other over-the-counter medications used to treat cold, cough, and flu symptoms. So if you or your loved one is diagnosed with DLB, always look for diphenhydramine in the ingredient list and avoid any medications that contain it. Third, anticholinergics should be avoided as they have many side effects, particularly in older adults and patients with DLB. Importantly, pharmaceuticals in general can do really strange and unexpected things in people with dementia, but particularly in patients with DLB. So it is really important to check with your doctor before taking anything new or changing the dose of a medication that you're already taking. Finally, anesthesia can cause complications in patients with DLB. So if a surgery is ever needed, be sure to talk to your doctor ahead of time about you or your loved one's DLB diagnosis. There are non-medication interventions that have been researched in recent years. Diet is a big one and something that we can actually control. The MIND diet, which emphasizes the foods listed on this slide, is a really proactive way of keeping our bodies functioning optimally. Also, avoiding ultra-processed foods is another way that we can try to stay healthy and give ourselves the best option to fight off disease. Altering diet is not a guaranteed way of preventing DLB, so much as a way of optimizing cognition. My mom, for example, followed the MIND diet unintentionally her whole life, and she still died of DLB. But perhaps her cognitive symptoms would have been significantly worse if she hadn't taken such good care of herself. There's no way to know for sure. So I don't want to build false hope, but I think it is worth trying the things that we have control over, and diet is definitely something we can control. There is also some really compelling recent research into the MIND diet, with studies that have tracked people's cognition over time and have found measurable evidence that this diet enables cognitive resilience. There are also some physical, mental, and social interventions that may be therapeutic. Exercise, particularly exercise that encourages repetitive movements, is greatly beneficial. Speech and occupational therapies can be helpful. Outdoor activities when the weather is nice, as well as games, music, and art. Basically, what you love and whatever makes you happy are really important for mental well-being. With DLB, routines are particularly crucial for functioning. So finding ways to establish routines and sticking to them can make the journey a bit more manageable. I added a quote to this slide about music because I feel like it captures how something as seemingly simple as a melody can impact our emotions, mood, and consequent brain neurology. Next, I will go over some resources for patients and caregivers. Support groups and educational opportunities are an excellent way for patients and caregivers to connect with others experiencing similar challenges. One local support group that I highly recommend is run by Pat Snyder. If you are watching this video on Pat's YouTube channel, then you have likely already heard of her. Pat lost her husband to DLB and has devoted the years following his death to helping others get through this difficult journey, and in particular, caregivers. Pat runs a Wake Forest Dementia Caregiver class, which is offered in person and via Zoom monthly. If you want to be a part of this group, you can email Pat at the email address listed on this slide, and she will add you to the group mailing list. She also moderates a support group called LBD Caring Spouses. She wrote a book called Treasures in the Darkness, which is a very inspirational and positive book, particularly if you're dealing with the early stages of DLB. The Duke Dementia Family Support Program is a fantastic resource that is not limited to Duke affiliated individuals. They have numerous services that are education, support, and caregiving related. They do wonderful work, and their website is listed on this slide. If you are a family caregiver, you might be interested in participating in a study called Persevere, which is funded by the National Institutes of Health. Persevere is interested in learning if a caregiver-centered educational intervention can improve caregivers' knowledge, confidence, strain, and health outcomes. And in turn, they are hoping this will help DLB patients. All participation is virtual and there are no in-person visits. If this is something that appeals to you, you can find out more information via the link at the bottom of this slide. There are numerous dementia organizations that have tremendous resources. I would like to particularly highlight the Lewy Body Dementia Association. They have a large assortment of articles, care summaries for patients, caregivers, health professionals, and donors. They also have a 24-hour caregiver link or Lewy helpline, which I personally used on more than one occasion when I was caring for my mom. Each time I called, I was connected to a social worker or a healthcare professional, and they helped talk me through my concerns. A couple of things I want to highlight that you can find on the Lewy Body Dementia Association website. The first is a link to a downloadable medical alert card, which is something of potentially great value, particularly if your loved one with DLB is ever in a situation where you are not with them. This medical alert card lists emergency contacts as well as provides warning for health professionals who may not be as familiar with the dangers of antipsychotic medications in DLB. The second thing is a downloadable link to the Diamond Lewy Management Toolkit, which is specifically designed for clinicians, but I'm calling it to your attention in case you want to bring it with you to your doctor's appointments. As many of you have likely experienced, some doctors are more knowledgeable about DLB than others, so it can be helpful for those who know less about this disease to see some of the management guidelines in writing. The LBDA has several research centers of excellence around the country, and one of them is here locally at UNC. Dr. Andrea Bazzoki, who I contract with on some local initiatives, is the principal investigator for the UNC LBDA Research Center of Excellence. Dr. Bazzoki is a neurologist and a tremendous advocate for those with DLB as well as other dementias. In October of last year, the LBDA and the Food and Drug Administration held a joint initiative where patients and caregivers chosen from a representative sample shared their personal experiences with DLB and offered their hopes for the future of DLB drug development. I was fortunate to be one of the panelists and was humbled by the stories that people had the courage to share. If you are interested in watching some or all of this informational event, the link is available on this slide and can be accessed through YouTube or the LBDA website. The North Carolina Registry for Brain Health is also a wonderful resource. They partner with various North Carolina-based academic institutions that are listed on this slide. Through their website, you can enroll and learn about research studies that those with a brain disorder can participate in. The primary goal of this registry is to expand our understanding of brain health and bring participatory research projects into the community. The Dementia Alliance of North Carolina is another fantastic organization that provides caregiver and patient support information, dementia education, research, and local events. Another local research initiative is the Duke UNC Alzheimer's Disease Research Center, or ADRC, which is a collaboration between researchers, physicians, staff, and patients in Eastern North Carolina. The ADRC focuses on identifying early and midlife factors contributing to Alzheimer's and other related dementias. If you are interested in getting involved in research with the ADRC, you can join the Alzheimer's Disease Discoveries in Medicine roster, also called Add Me, and you will be contacted about participating in related research clinical trials. The QR code can be found at the bottom of this slide, as well as a web page link if you prefer to use your computer to fill out information. The Alzheimer's Association also has excellent material. Even though Alzheimer's is different from DLB, many of their resources are applicable to handling dementia-related challenges, particularly for those patients and loved ones that are dealing with overlapping dementias. They also have a 24-hour helpline for people seeking disease management advice. The final organization that I would like to highlight is the Brain Support Network. Their website has links to national and international support groups for DLB and other brain-related disorders, as well as links to many educational resources. If you or your loved one is considering brain donation, they can arrange that for you. This organization helped me donate my mom's brain. Many years before she died, my mom had signed all the paperwork to have her body donated to medical research, as my dad and grandmother had done. But because my mom ended up weighing so little towards the end of her life, no organization would accept her body. My mom was a professor her whole life, a huge advocate of continuing education, and a person who dedicated her life to others. So the thought of her years of suffering, not being able to help someone else, was something I found really difficult to accept. I began searching for an alternative to body donation and was fortunate to find the Brain Support Network. They arranged for my mom's brain to be donated and, importantly, placed directly into the hands of Lewy body researchers. I realize that talking about brain donation is a difficult topic, but at least for me, there was something quite beautiful about this process, and that it gave my mom the opportunity to continue to help others and to continue to teach infinitely. The Brain Support Network also provides a full pathology report to the loved ones of the person who donated. This pathology report meant more to me than I realized it would, because it confirmed my mom had full diffuse dementia with Lewy bodies. Mom was never diagnosed with DLB while living. She was misdiagnosed with Parkinson's disease, although I always suspected DLB. So seeing the correct diagnosis in writing provided some relief to finally have an explanation for so many seemingly inexplicable things that we had been through together. Next, I will briefly talk about managing the everyday challenges associated with DLB. This is primarily directed towards caregivers, although patients may find some benefit as well. Due to hallucinations, delusions, and cognitive changes, DLB can cause fluctuating levels of alertness, attention, and mood. These changes can be sudden. They can last for minutes or hours or days. One of the most challenging things for me was not knowing what to expect on a day-to-day basis. So the suggestions on this slide fall into the category of easier said than done. I am by no means saying these things are simple to do, particularly when you are in the throes of caring for someone, but they are things to keep in the back of your mind and to try when possible. The first suggestion is to try to stay calm. If you can stay calm, then there is a chance that the patient will not be as agitated as they would be otherwise. Alongside this, talk slowly and reassuringly. Try to not take things personally. Recognize that when hurtful things are said or violent behavior is exhibited, it is the dementia at play and not the person that you are taking care of. Always reassure the patient of their safety. Even if they are not saying they are scared, there is a chance that they're scared. Many patients cannot express their fears due to loss of language or confusion. I think the unknown in and of itself creates a sense of fear. And then coupling this with the fact that most DLB patients are able to maintain their awareness, it must be terrifying to be aware enough to know that your mind is not working the way you want it to. So anytime that a patient can be reassured that they are physically safe, you, their caregiver, are safe, and you love them, sometimes this is all someone needs to feel some peace. Distractions can sometimes help and sometimes they don't. There were times when distractions got me through the day with mom, and other times they did nothing to ease her mind. Next, you have to keep trying. You never know what strategy will work one day and not the next, or vice versa. You have to remain resilient and keep trying new things. Finally, Dr. Coffer, who some of you may remember, was a wonderful neurologist who specialized in taking care of patients with DLB as well as frontotemporal dementia. Sadly, he passed away suddenly from cancer several years ago. He was once asked how to interact with dementia patients, and he said, "Honor who they are." I think what Dr. Coffer was saying was that no matter how far advanced a person's dementia may be, the person that existed before the dementia is still in there somewhere, and they likely do not want this diagnosis to define them. If you can find ways to reach that person, respect that person, and make them feel their value, then you are honoring them, which is a beautiful gift. This slide is a simple reminder that sometimes the little things are big things and they can help you get through the day. First, schedule breaks, even if they are small and even if you don't think you need them. A few minutes to clear your head can make all the difference in the world. Next, find someone to talk to. It could be a professional person like a counselor, or it could just be a friend. But having someone to talk to and sharing your day-to-day experiences is invaluable for your mental health. Try to get outside. Just breathing some fresh air can sometimes reset your mind. Be kind to yourself. Accept that you will make mistakes. Remain cognizant that everyone is functioning under extremely difficult circumstances. So there's a level of empathy that needs to be brought to the room. And everyone in the room is in need of receiving that empathy, including the caregiver. Focus on what you can control. The unexpected is one of the hardest things to manage in life, but particularly in a condition like DLB, where symptoms can fluctuate from minute to minute at times. I never knew what to expect when I went to mom's house, and I developed some anxiety strictly because there was no predictability to anything. Next, ask for help. Recognize that what you are doing is incredibly hard, and you can likely do an even better job if you ask for help. Finally, if you are able, do what brings you joy. There are some books that are incredibly helpful, and a few are listed here on this slide. Give you a moment to take a look at those. There are a few clinical trials for DLB. If you're interested in researching them more, the best way is to go to the LBDA trial tracker or the clinical studies link that's also on their website. These are my references, and we've reached the end. Thank you so much for attending today. I very much hope this presentation was informative and helpful.